Joining me now to react, we have Dr. Michael Osterholm. He is the director of the Center for Infectious Disease Research at the University of Minnesota. He is also the author of Deadliest Enemy, Our War Against Killer Germs. Doctor, thank you so much for joining us. And also we have Eileen Sullivan. Eileen Sullivan Marks. She is the president of the American Academy of Nursing and the dean of the Rory Myers College of Nursing at NYU. Thank you so much to both of you for joining us. Dr. Osterholm, to begin with you first, you've been warning for at least a decade that the U.S. was not prepared for a pandemic. When you see this report and you know this was an exercise that had been done and had revealed the very limitations that we are now seeing demonstrated in real time, what does that tell you?
Well, thank you for having me. First of all, let me say I actually wrote about them the first time in 2005 in the New England Journal of Medicine and Foreign Affairs that we were not prepared for the next pandemic, and I must say we were better prepared back then than we are today. I'm aware of this report. In my book in 2017, Deadliest Enemies, I actually had a whole chapter that actually portrayed a theoretical pandemic as it unfolded from China, a flu virus in this case, but acting the same way. And it's actually almost read script by script what's happening right now. We knew this. We had warning, and we just, as a world, not just the United States, but as a world, we neglected to prepare.
If I can ask you, Doctor, just really quickly, why is the U.S. less prepared now than it was in 2005?
In 2005, we actually had much greater medical capacity to respond. We had more beds. We had more care provision capability than we do now. The other thing that happened was in 2005, we didn't depend on distant supply chains that go back to China for many of our critical drugs and medical supplies. Today, 85% of all the antibiotics that we use in this country are made outside of the United States, and they're very fragile just-in-time delivery systems. So over the course of the next several months, we're very concerned about the drug shortages we're going to see that are going to develop secondarily to the problem in China and the lack of transportation around the world.
Eileen, what is your response to this report as coming from a nursing perspective, as a health worker, knowing that there was a number of warnings, exercises that showed there should be warnings, and yet they weren't heeded?
Thank you. Thank you for having me on. I mean, nurses are the front workers in so many cases 24/7. There's many frontline workers. We often locally have preparation related to pandemic responses, but it's just one of a number of things we prepare for. And I agree with David in the sense that the world probably took it a little bit for granted, and that's not uncommon. Things that we're used to, like getting the flu, we sort of say, okay, we're going to get a flu. And I think that's how we ended up not being totally prepared. I would agree that we haven't been thinking about the overall supply. When we talk about nursing shortage and we talk about changes from using hospital beds less, moving people out to ambulatory care, now we have to ramp up and get people back into ambulatory care. One of the things that I'd like to talk a little bit about is this idea of, do we have a drug that's going to fix things quickly? The best way that people can get the best treatment is with the care of the right people at the right place at the right time. Nurses, they are 24/7 with you while you're dealing with this illness, whether or not you're on a ventilator, but the fluids that you need are the most important critical treatment that can take place. And if we don't have the right equipment for the nurses at that place, or the doctors, or the respiratory therapists who need to be there, then they're at risk. And they're at risk for getting sick, and they're at risk for perhaps not even being available because they are sick. So you have to really think imaginatively. As I have said to others, we may need to be stretching now into use of the federal workers from U.S. Public Health Service, military. This is what we have to start looking at quickly to catch up.
And I want to know from both of you, and you'll have to excuse me as I hold my earpiece here. It's how I can hear you better for some reason, Eileen. But Dr. Osterholm, when you're looking at this guidance now coming about how frontline healthcare workers can basically reuse masks, they can use scarves, they can use bandanas in a pinch if they have to. I mean, it's obviously a last resort. But what kind of concerns does that raise for you?
Well, the first concern I have is just credibility. We keep hearing from this administration that we're going to have these products. The manufacturers, for example, the N95 respirators, have been operating at 110% capacity for the last 2 months. There's nothing new that's going to happen. We are going to be hundreds of millions of N95 respirators short of protecting our frontline healthcare workers, which is absolutely essential. With that, then we're going to have to get creative. We're going to have to say, okay, if you don't have that, will you do this? Will you do this? Meaning, will you use a surgical mask? If you don't have a surgical mask, can you craft somehow something else? These are surely not nearly as protective. We're going to be asking healthcare workers to almost go into a battle like we asked our soldiers to do. They're going to walk into harm's way, not away from it. And, no amount of extra effort with bandanas, whatever, are going to stop that. They may mitigate it a little bit. They may lessen it a little bit. But I think we are going to be counting on our brave healthcare workers to help get us through this for the next however many months.
We certainly are. Yeah, Eileen?
I said I agree totally. This is going to come to the core of who we are and what we do. We will move forward. I know people that are already crafting gadgets. Think about all the people who aren't in hospital situations but are caring for people who are in sheltered situations, people who are living in group homes, people who are living in homeless shelters, people who are in long-term care. While we do want the mask in the big health systems, those folks are realizing that they don't have the right masks, but they're staying where they are. And we need to pay attention to those groups of people who have to live together, who don't have any other choice. And what are we doing there for social distancing as well, so that then they don't end up in the emergency room in ICUs.
Eileen Sullivan-Marks, thank you so much. Dr. Michael Osterholm, we really appreciate your expertise today.
Thank you.
Thank you.